So I think we'll get started. Since it's the last day in January, and I'm not sure in the rest of the province, but today it's actually quite warm out, and I think it's -2, so it's surprisingly much warmer than the -25 that we've been experiencing the last few weeks. I think just a few quick reminders. The RGP does an annual refresher day, and once again, I think it's quite a strong agenda that's been put together for March 5th. So if you haven't registered for that, I just encourage you to register that. Registrations are coming in quite fast and furious, and there's limited spots, and we've hit 300 the last few years, so it's a great opportunity, and it's actually cost effective because I think it's $90 for the event, and it's CME, so it's Main Pro accredited as well. And then also the University of Ottawa has a CME education event for June 6th, and that agenda will be coming out shortly, and again, that's Main Pro accredited, and it's run by the Faculty of Medicine, University of Ottawa Continuing Medical Education Department. So I think we'll get started with today's presentation on Champlain 2020 Integrated Dementia Care Model, Making Choices That Matter. And I just wanted to go back a few years, and I think one of the things that was quite instrumental in really moving this forward to where it is today are the caregivers. And we're quite blessed that we have two caregivers from Mind the Gap that will be presenting, or one will be presenting later, but Rosanna and Marcella are here today, and I think it's quite a pleasure, and I think really listen to their journey and their experiences that they've gone through over the years. Because I think it's really important for all of us to take that to heart when we're going out and working with patients, but also working with the system and trying to improve it to make it more effective for persons with dementia and their caregivers. I'd also like to acknowledge the work of Dr. Molnar, Kathy Wright, Dr. DeZille, and many others, to just name a few, who advocated a few years back for our LHIN to develop a dementia care strategy. And I applaud our Champlain LHIN for being progressive and developing a Champlain Integrated Dementia Care Strategy in partnership with the Champlain Dementia Network, the Regional Geriatric Program, and the Regional Geriatric Advisory Committee, and all of their hospital partners and partners across the region. Key members from across the region were instrumental in developing the first, not only for the Champlain in a dementia care strategy, but the first for the province of Ontario, and actually for the nation of Canada. Canada is still the only G8 country without a dementia care strategy. The LHIN has continued to support the strategy, and one particular area which aligns with the RGP's priority is seeing how we can strengthen our key partnerships with primary care. It's a year ago that we brought Dr. Lee and Dr. George Heckman to Ottawa to discuss the memory disorder clinics that could be integrated within primary care. And in February, under the leadership and guidance of Kelly Lumley Leisure, Dr. Lee and her team will be collaborating with 5 primary care teams in Champlain, and that's the first of 3 waves of 5 teams, so a total of 15 teams over 3 years that will be built and developed and mentored and coached by Dr. Lee. So it's also my pleasure to introduce Cal Martel and Marcella, who's a caregiver and also quite involved with Mind the Gap. Cal is a leader in health service delivery and planning with more than 35 years of progressive experience at regional and provincial levels. And Cal doesn't even look over 40, so I don't know when he started. He must have started when he was 5 years old. His career included roles with the Ontario Ministry of Health and Long-Term Care, the Regional Geriatric Program of Eastern Ontario. He also served as the chairperson of the Regional Geriatric Programs of Ontario from 2003 to 2009. Held an appointment at the School of Management in the Masters of Health Admin program here at the University of Ottawa in Community Health and Long-Term Care. He has a consultation practice for the past 4 years in seniors health and primary care, focused on integrated service delivery. And Cal was the key consultant that was involved with developing the integrated dementia care model strategy. And he's invited to present at international conferences. Just recently was in China presenting on the topic of integrated healthcare service delivery, and currently serves as the president of the Council of Aging of Ottawa, where he began his work with seniors. We're also pleased that Marcella will be joining Cal in presenting, and she's a caregiver for her husband and a member of Mind the Gap, a group of 5 wives who have been caring for their husbands who have dementia. They met at the monthly wives support group run by the Alzheimer's Society of Ottawa During one of these meetings, they heard yet again that someone was having difficulty with the system that is supposed to help people with dementia and their caregivers. In an effort to find out why the system wasn't working, Marcella contacted her local MPP, Bob Shirelli, and at a meeting was arranged with him, as well as the CEO of CCAC Ottawa, a CCAC board member, and a case manager. That was a year ago. Some of the organizations and individuals with whom Marcella has met with over the past year are CEOs and board members of organizations such as the Champlain Lynn, the Pearly Rideau Veterans Health Center, Care For, the Memory Disorder Clinic at the Briere Continuing Care Center, the local Alzheimer's Society, Council of Aging, MPPs, and most recently with MP Claude Gravel, who's been quite active in trying to get a passing for a dementia care strategy for Canada. So please join me in welcoming Cal Martel, and then Marcella will be joining up later with Cal's presentation. Thank you.
Thanks very much, Kelly, for that kind introduction. It's been great to work with you and Frank and others again. Good morning, everyone, and it's nice to be back. The dementia is the leading cause of death and disability in seniors, and within Champlain, it's the third leading cause of death overall across populations. So we're really pleased that the Champlain Lynn, as Kelly had mentioned, as a result of early planning done by many in the community, had adopted and made a commitment to do a more coordinated approach for dementia care. And this project is one which they funded last year and was conducted during the period from January to March. So really our objective for today is just to give you a brief overview of sort of the rationale and the framework for the project, where we're going with it, but also an understanding of the potential impacts it can have both on the lives of people with dementia and their caregivers in that respect. So I'll start, again, just a brief overview, why we are taking the approach we did, what the framework or roadmap for integrated care for dementia looks like here in Champlain, and then we'll have some time for questions, and I think Frank will quarterback that piece along that way. So we started out initially just really scoping the and defining how far we wanted to reach in terms of an integrated approach, and really the project team was really looking at all in, no restraints or parameters around we only want to have coordinated access or information referral, those types of things. So we really covered the ground, and you'll see from coordinated funding to governance to evidence-based practice and so on and so forth. But really benefit, I think, with the work the RGP did with Dr. Linda Lee around the primary care memory clinics, because it really started to engage the primary care practices, at least some of them, in discussing what their readiness was in terms of building capacity for dementia assessment within their practices. And then the next, again, as Kelly had said, we don't have a national dementia strategy, but we did review 8 others in 8 other jurisdictions. I was going to say countries, and for those of you who would view Quebec as a nation, I guess 8 nations in that respect, but and really look more for the strategic framework, because most of them were policy statements, and then went into having some very focused interviews with caregivers and people with dementia in some areas in terms of what are the types of outcomes they wanted us to achieve. Went through an environmental scan, and most of this was data mining. It's very hard to plan for services if you don't know where and how people are using the services, so we're really trying to get a good picture of that. And we actually worked with about 8 different data sets to give you the profile we'll show in a little bit later. Then went into the whole process of analysis, really trying to examine the different ways of integrating or putting together the different strategies we built into the framework. Went through with our advisory committee, tied that all together, and did a rapid fire consultation over a period of about 2.5 weeks, and then tied up the report March 31st. So that's the work we did last year. That'll be part of what we're sharing, but then also will give you an idea of the next steps, because we're now on to implementation planning at this point. In terms of the rationale for change, here in Champlain, at this point in time, there's 18,400 people with dementia. That's roughly 10% of the population of seniors. 3,100 new cases every year. And of those, 64% has been identified are not being assessed or diagnosed early enough to really take advantage of promotion prevention strategies. And more than 60 of people with dementia have 3 or more chronic conditions, and that'll be a theme that will come up as we go through the presentation in that respect. So it's really the combination of the complexity of the disease with the comorbidities that leads to a high level of interaction with our health system in that respect. So talk a little bit about the profile that we've developed. Champlain, by the way, has the 4th highest number of people with dementia of the 14 LHINs in that respect. So it's another important reason why they should be looking at that. And the number of people, or the proportion of people with dementia, will be increasing 30% between now and 2020. Hence our, that time in our target in that respect. Of these, 13,600 are living in the community in that respect. So most people with dementia are living in the community. 175,000 primary care visits each year with people with dementia across the region. And this was developed from some excellent work done on the frail older persons with ISIS in 2011. Also sort of an opportunity lost when we hear that up to 80% of the people who go to their family physicians are referred on to specialists for diagnosis and assessment. It really gives you a sense of what some of the opportunities are there around primary care. 55,000 day program visits. It's an important and growing role in the region, and when we're starting to look at more integrated approaches to care, the day away programs is certainly something to keep in mind. Almost 1 in 4 people with dementia in the community have a visit to a hospital ED. Implications there for geriatric emergency management and various others in terms of pickup. 5,200 across the region are served through CCAC. And 1 in 4, just under 1 in 4, are admitted to hospital each year. And here's the kicker. Those 1 in 4 who are admitted to hospital account for 34%. Not of alternate level of care days for seniors, but of all ALC days in the entire system. And this is nationwide in that respect. So it really gives you a sense of where we need to be looking if we're really going to have an impact both on quality of care and utilization outcomes. 3,300 people living in retirement homes. So again, an important area to look in terms of ongoing care and support. And of the 14,600 living in the community, approximately 1,100 end up requiring placement in long-term care each year. And looking at the number there, it's approximately 64.5% in our region of the people in all the long-term care beds are people with dementia in that respect. We talk about the needs of caregivers. So there's more than 3,100 new caregivers, because each person with dementia has 1 to 2 caregivers that are sort of knocking on the doors and struggling with this challenge. With the first link through the Alzheimer's Society, they receive 1,300 new referrals each year, which is very encouraging, but still more work to do. Marcella will talk a little bit more about the experience of caregivers, but it's important to understand that 35 to 60% of the caregivers of people with dementia experience a decline in their own health in that respect. And 71% will experience interruptions in their employment. We got great support from the CCAC in their decision support, and I'm showing a little bit of the data here. First and foremost, just to validate the data extrapolation we did. So the ISIS data, as we'd said, indicated there would be about 5,200 people who receive services from CCAC. When we looked at the actual numbers, you can see there's about 5,100 people across the region who get ongoing support from the CCAC, and there's an inkling here of the split between in their own homes versus retirement homes and homemaking and various other services in that respect. So it's not insignificant. 30% of all people with dementia living in the community receive homemaking support from the CCAC in that respect. Just looking at those with more moderate to severe, you can see, and this is just to give you an understanding of the experience that Marcella and Roseanne and others are dealing with. The burden of care in people's own homes is the same or even greater in some circumstances than those who are living in more supported environments in retirement homes. These RAI scores talk about an overall level of dependency. The MAPLE score is a priority weighting for long-term care in terms of needing those levels of service. And CPS stands for Cognitive Performance Score. So I won't go into those to detail, but it just gives you a bit of a stark comparison in that respect. So we talked earlier about the importance of understanding the impact of dementia on other chronic conditions. And we were really helped with some early work that Dr. George Heckman was doing in Waterloo, Wellington, and Dr. Lee in the early part of this work. Dementia and delirium accounts for 6 times more ALC hospitalizations than diabetes, hypertension, and asthma combined in that respect. So when you're really looking at the effect of chronic conditions, Frank sometimes refers to it as the godfather of chronic disease, or you get the domino effect of dementia and so on and so forth. But it really underlines, and conceptually we need to understand, how dementia affects the capacity for self-care. But also that there's a correlation between a number of these other chronic conditions. And this is sort of based on the work that Dr. Heckman was doing. When we share this with clinicians, they will often remind us very quickly, don't forget diabetes. There's a heavy overlay there as well in terms of some of the other key chronic conditions. But this group, people with dementia and other chronic conditions, account for 90% of all the dementia-related ALC days, which is 1/3 of all the ALC days in the system. Talk a little bit about caregivers now, and again, because of time, we looked at existing data for the most part, although we did go out and do some focus groups. There was a wonderful study back 2004-2005 done by the Murray Alzheimer's Research and Education Program at the University of Waterloo. It's called In Their Own Voices. They interviewed over 2,400 dementia caregivers across the province. So this is some of their perspectives, and really underlines the frustration and challenge of caring for a person with dementia in their own home. But it's not just because of the consequences of dementia. There's a lot of that burden is a direct result of how we provide services. And so we talk about not enough hours, too difficult to navigate, don't have any control, bureaucratic procedures, and cost. Now, actually, I've met a couple of times with Mind the Gap, with Roseanne, Marcella, and others, and they see this slide. They actually politely gave me heck. I said, because the issues are absolutely bang on. The proportions and the ratios make no sense. They really understate the burden of people who are living in the own homes with persons with dementia. So I promised I would do that. So we'll focus on the issues and really not the proportions. But it was really interesting. We did do a survey out to 47 agencies in Champlain region to get an understanding of what they thought the barriers were for people with dementia and caregivers. Same types of issues, but a much stronger opinion amongst the people providing care that we're not doing what we need to in that respect. At the same time last summer with the Alzheimer's Society, there was another Ottawa needs assessment done with caregivers. A combination of 400 online and focus groups were done. I'm not going to dwell on this too much because now you're going to get the real scoop from Marcella, who I'm just so pleased and honored that she's been able to come and join us this morning along that way. So Marcella.
Good morning. How many of you in your personal rather than your professional lives know someone with dementia? Imagine a person living at home with dementia. He has signs of social withdrawal, aphasia, apathy, confusion, especially late in the day, paranoia, hallucinations and repetitive behavior, denial of symptoms, emotional moodiness, and sometimes aggressiveness. Now think about his caregiver. In my case, I have taken care of my husband for 8 years since his dementia diagnosis. He also has cancer and diabetes. And since my heritage has a very strong influence on me, taking care of him at home for as long as possible seemed the only option. I grieve for the person that I married 56 years ago. I cry, but I cannot do this for too long, as there is always a lot to organize. For example, to come this morning, I had to make a number of arrangements. My husband cannot be left alone. The day away program he attends does not start until 9 a.m., and since I needed to leave home at 7, I needed help for him. As it happens, I do not qualify for a personal support worker from the Community Care Access Center, the CCAC, as my husband does not need personal care such as bathing. There is a certain bureaucratic inflexibility regarding the needs of the caregiver, no matter what the challenges are at home. To prepare for this morning, I had to wake up my husband early so that I could give him his medication and his breakfast. Some of his medications have to be taken with food. I had to engage a person to stay with him and ensure he was dressed on time and ready for the drive to the day away program. A second person privately engaged will drive him to the program. The costs of all these arrangements count up. I'm reminded of people who cannot afford these private costs. What do they do? The costs for me are not just financial, but psychological. In everyday life, I must think about these complex arrangements each time I need to go to the dentist, the doctor, or for any emergency that arises. The emotional cost is high and includes loneliness, sleepless nights, and grief at slowly losing a loved one. Also, there is the stress and anxiety of trying to do what is best for my husband. This I do with some support of my friends and family. And with all this, there is a social stigma and around dealing with someone with dementia. All this takes a great toll. Recent events have unfortunately changed my life 180 degrees. In July, an excavator rear-ended my car, and up till that time, I thought I was coping reasonably well with the caregiving. I had to buy a new car, which I had never done in my life, and it stressed me terribly. I also had health complications after the accident. I started to have pains in my muscles and began physiotherapy and massage therapy right away. The problems continued. In November, I had a medical test that showed that I had elevated muscle inflammation. After more tests, the levels appeared normal. However, I was cautioned that if I had problems with my jaw, eyes, or head, to seek medical help right away. On November 16th, I noticed that I could not see anything from my left eye, and immediately went on an after-hour clinic and then was sent directly to the Civic Hospital. I had blood work done and was put on prednisone. There were then appointments at the Eye Institute, and I was put on 1,000 milligrams of prednisone by intravenous for 3 days to try to save the sight of my other eye. Then I needed a biopsy of the arteries leading to the brain and an MRI. The diagnosis was giant cell arteritis, and I was not given much hope of sight recovery of my left eye. Throughout this trauma, I had, of course, to make arrangements for people to stay with my husband many days and nights. This was not an easy task, and it was very costly. I have accepted that I have lost the sight of one eye. Now, I must take a decision about long-term care for my husband, and with a breaking heart, and with the advice of my family and doctors, I had to decide that my husband needs to go to a long-term care facility because I cannot look after him anymore. This runs against my culture, which I hold so dear. In conclusion, I want to say how grateful we are for all the health professionals and their support of our loved ones. However, I would ask that when you are providing care for a person with dementia, that you remember that you don't only have one patient, but you also have a caregiver as well. In the course of your work, please help us keep our loved ones at home as long as possible and support the caregivers to find resources to help us through this journey. If you provide such assistance, believe me, we will be eternally indebted to you. Thank you.
So Marcella's husband is currently on a waiting list for a long-term care bed. And as she said, the hours of help that she's currently getting at home just aren't enough and are too expensive for most people. So we're reminded that many people with diseases are able to speak for themselves. People with dementia cannot. So it's absolutely critical that we find ways that caregivers such as Marcella and the others are able to have a voice, both in terms of how we plan and support them, but in terms of how we plan and support the delivery of a system of services in that respect as well. I'll talk a little bit more about that as we go along. I wanted to thank you both for your courage in sharing your story, Marcella, but also the conviction that you and all of the members of Mind the Gap and others have shown. They are doing a lot of heavy lifting out there in terms of advocacy right now, as Kelly was saying, and they know that the benefit of their work is going to be for people coming behind, not for themselves in that respect. So I really applaud you in that respect. But the moral of that story is, the system really is not designed to respond to the needs of people with dementia and their caregivers, and others might just say it's not a system at all in that respect. So that's really sort of was the jumping point when we were starting to look at different approaches to care. So I think there's a very convincing case that the consequences of dementia, both on people with dementia themselves, the other chronic conditions that they experience, on caregivers, and on the health system as a whole, place a tremendous burden. But there's also an equally convincing case that earlier diagnosis and intervention, prevention, caregiver support, more coordinated access to care can do a lot to alleviate that burden of care and help people adapt or live well with dementia. And that was really sort of one of the fundamental principles that underlines a lot of the work we did with this strategy. And there's 6 strategies and outcomes that are here. And this really came out of the reviews we did of the strategies in the other countries that range from Quebec through to UK, Europe, Ireland, down to Australia, US, and so on and so forth. And from them, we identified a range of outcomes they were working on and then did a consultation initially with our project team and then with the community just around what outcomes. If we're looking at changing dementia services, what should we be achieving? And so these 6 outcomes in terms of public awareness, where you're wanting to improve awareness and community support for people with dementia, earlier diagnosis and detection, promotion of activities and attitudes to live well with dementia. Normal health promotion talks about behaviors, but people with dementia have heard enough about behaviors, so we talked about activities in that respect. That people with dementia and caregivers know what to expect and where to find it. Sounds so simple. And yet for the past 20 or 30 years, it has been the same challenge, both for providers and caregivers alike. That through coordinated access, we want to prevent and manage the complications of dementia, and also do that away in providing choices that matter to the person with dementia and their caregivers. It's a disease that shows itself different in each person, and also it's very sensitive to the context they're in. So they need to be able to really identify what and when are the priorities for different levels of service. Cookie cutters solutions really won't work here. At the end of the day, looking at tying this all together with a more integrated approach that provides a system of care and support from public awareness down to care and support that's really tailored and targeted to the changing needs of people with dementia. And these are just some of the, I want to go back actually on this if I may. So when we did the consultation, 99% of the respondents agreed these are the outcomes we need to be working for. So a resounding consensus. And so from the get-go, these are the outcomes that have been driving what we do. Behind each of those 6 strategies, through the consultation and with the project team, they identified about 37 different activities that should be considered to move towards those outcomes. And these are just examples around the coordinated access piece. The full 37 are detailed in the document itself if you wanted to look at that. The Alzheimer's Society of Canada obviously has been promoting the need for a national strategy for dementia for many years, and it sounds like it's getting a little bit of traction now. Sort of the 4th plank in their strategy, though, was to identify the need to integrate best practices in chronic disease management with coordinated community care to provide a more integrated approach. And that's essentially what we've tried to do here. We've taken best practices around chronic disease management, looked at how those play out in dementia strategies where they've developed in other jurisdictions, and have adapted and translated that into a plan of action or a model of care that we're going to move forward with here in Champlain. In terms of how we tie it together or integrate all these services, the slide talks about an integration toolkit, but it's basically, there's a menu of clinical and administrative best practices that has been around for about 15 years that Marcus Hollander and colleagues developed out in BC. They did national best practice reviews, and it's called Best Practices for Organizing a System of Continuing Care. And so when we were looking at where we wanted to go around integration, it was really those 5 administrative and 5 clinical best practices that we started looking at, and will continue to look at with the community and the steering committee as we move forward. But there's fairly straightforward and sort of some self-evident. You need a clear statement of philosophy in terms of where you want to go. A highly coordinated administrative structure. That's your governance. How do you make decisions? Who's involved in making the decisions? Having a single funding envelope. In other words, making sure there's financial incentives for people to play together in the same sandbox, and so on and so forth. Around clinical, these are the same types of issues many of you are working with already. Having coordinated entry or access, consistent assessment practices, ongoing system-level care management, they talk here case management, and, as we were talking about just with Marcel, involvement of clients and families. So that's sort of the menu of issues we looked at initially in developing the model, but also recognizing you have to have linkages with the rest of the system in terms of primary care, acute care, and other populations, with other chronic disease populations, and so on and so forth. And so we translated all that into this is basically a picture of the model of dementia care we're moving forward with here in Champlain. It's essentially a roadmap which talks about the 6 strategies, really looking at self-management and caregiver support that will, again, promote activities and attitudes to live well with dementia. A system navigation that allows people with dementia and their caregivers to know what to expect and where to find it. It's probably going to be the toughest challenge of all. To bring all of the continuum of care together around the experience of people with dementia so we can prevent and better manage the complications of dementia, and do that in a way that allows the people affected to make those choices that really matter. And at the end of the day, tie that all together with shared decision-making, coordinated funding, evidence-based practice, common screening and assessment, system-wide care management, and a highly integrated, coordinated approach to education and training for professionals across along the way. We're doing good. So that was the plan, and that's where we ended up last March. So earlier this year, the LIN funded some initial investments to start moving forward with the implementation mode. This is really going to be a labor of love, I think, for many years. We identified 2020 as a target to make everything happen, but we don't know if it'll take that long, but that certainly will take a period of years. These priority actions were the ones the community identified. So when we're looking at the 6 strategies, so around public awareness, there was strong interest that we enhance the role of communities and neighborhoods in being able to support people with dementia and their caregivers. And there was a lot of coverage in the news at the time around the sort of the dementia cafes or regular cafes they have in Europe, where people can just go to regular parts of the community and connect and engage and so on and so forth. Early detection and diagnosis. So again, as Kelly was saying, there's a strong focus on building capacity in primary care. That was seen as a priority need by the community. And in terms of self-management and caregiver support, first and foremost, a comprehensive caregiver strategy. And most governments these days interpret that to mean tax credits and maybe some employment leave benefits and so on and so forth. We're talking about much, much more than that. Actually, Roseanne did some work around calculating the tax credits. I think it works out, if you look at both the combined federal and provincial caregiver tax credits, is it 53 cents an hour? So spare me the coffee, I guess the caregivers would say in that respect, and are really looking at a much more comprehensive range of services, including direct funding initiatives that are similar to what have been developed for some other populations. It's been very successful for kids in this province around special services at home and various others. The Veterans Independence Program is another direct funding pilot that has been very cost effective. It's improved the quality of care, allowed people to stay in their own homes much longer and save bucks along that way, all by giving the people directly involved more control over what happens to them along that way. Also wanting to work with the CCAC so that they identify the caregiver's needs as needs in their own right, not just as in relation to the person with dementia in that respect. And then a stronger focus in terms of future planning around developing some pre-orientation education to long-term care for the families in that respect. In terms of system navigation, interest in getting more coordinated intake and referrals, tracking. And in terms of pathways to support, dementia-sensitive acute care. And there's actually a good overlay here with some of the work that's happening around delirium and dementia screening in the senior-friendly hospital strategy in that respect. But the need to develop more dementia-specific housing. And so some of the initiatives that are moving forward now at the Pearly and I believe Briere with the Villages sort of supportive housing concept are very much in line. But also in the long term, and this is something Dr. Sinna's report talked, a more diversified role for long-term care. And again, enhancing supports for people with dementia in retirement homes. Looking at the potential to build stronger partnerships between community support services and the CCAC, and an enhanced role for pharmacy. When we had a lot of discussions at the Regional Geriatric Services, I think early in the fall, people felt there's an opportunity lost there as well in terms of what pharmacy can do around screening and medication management and so on and so forth. And then around system integration, it was around screening tools, case management, and alignment with the LHIN Integrated Health Services Plan, and along that way. And this is all the result of these folks here. It was actually a joy to work with the project team in developing this model. And they do capture the continuum of care from community support through to hospital, geriatric medicine, geriatric psychiatry, Alzheimer's Society, CCAC, and so on and so forth. When they were selected, and this was Frank who led this, they were never selected on the basis of where or what agency they were to represent. They were selected based on their demonstrated commitment to make a difference in the lives of people with dementia and their families in that respect. And it actually, we had a lot to do in just a couple of months, but the way these folks really came together was probably the key ingredient in being able to move forward as quickly as we did. So I'll just do a quick wrap up, if that's my cue. Okay, excellent. So just a little bit of reminder, because there's a lot of work being done around health links in this regions and elsewhere. So, I mean, people with dementias are saying this is a high-cost population. Do the impact of dementia on other chronic conditions need to be a central consideration in planning for health links? And although we want a more integrated approach to dementia care, nobody, caregivers, providers, are looking at creating another silo. It's really looking at how we can provide an integrated experience, but without creating sort of another system, separate system of care, and so on and so forth. So this year, the LHIN funded some initial, I guess, seed funding for the development of the model of care, and we established the sort of a regional steering committee. It's an evolution of the Champlain Dementia Network, and they had their first meeting in November, I think, and have now had 2 meetings. We've got an approach towards developing a coordinated funding envelope, and have really been working with that group in developing the role of caregivers in governance and planning. And in fact, I see Eleanor Ryan is here as well. We have 3 caregivers on the Regional Steering Committee. So that's 20% of the membership of the Dementia Steering Committee are caregivers in that respect. And it really is already starting to shape the focus of discussion and so on and so forth. As Kelly mentioned, we're starting to move forward with 5 of what will be 15 primary care memory clinics over the next 15 years. And also through the work that Briere is doing, are looking at evolving the role of the memory disorder clinic so it has more of a regional orientation. And right now, the Alzheimer's Society, through some of the funding they receive from the LHIN, are developing a marketing and public awareness strategy that will ultimately, over the course of the coming years, really change the conversation around dementia. And in terms of pathways of support, we've got dedicated staff liaison within the LHIN who are a member of the steering committee to make sure that we stay connected and aligned with the other work that they're doing. And you can see the initial investments in that respect. I won't go over the other parts. I did want to wrap up with this statement, and it's a little lengthy, but I'm going to read it, if you don't mind, Frank. So when we really started to do the lit review and research what the realm of the possibilities were around caregiver engagement, this is one that really stood out to me. So we've observed that in a growing number of instances where truly stunning levels of improvement have been achieved, organizations have asked patients and families to be directly involved in the process. And those organizations cite this change, putting patients in a position of real power and influence, using their wisdom and experience to redesign and improve care systems, as being the single most transformational change in their history. And that's from the Agency in Healthcare Research and Utilization down in the US, and is really a key focus of the initial discussions we've had at the steering committee in that respect. So Thank you. Yeah. Well, we've got some great people doing the work, right, for us in that respect. So just in summary, I think there's great potential in really having outcomes-based planning in terms of the type of future impacts. We really started with the end, right? What did we want to achieve? There's a unique opportunity here with a number of the contexts in the region and provincially for behavior change, and we're not talking about people with dementia here, that's us in that respect, and also really get to understand what the potential is to leverage new investments from the LHIN to change the existing way we provide services in that respect is along that way. So thank you very much for your time and attention, and I think we'll turn it over to Frank.
Well, thank you, Cal, and sorry I ran up early. I saw the list of names. I thought there was a thank you slide at the end, so I got excited and ran down. I sense we have a rowdy crowd here, so I'm expecting some good questions at the end. I'm just going to take this time to create a bit of a burning platform. It was the House of Commons Standing Committee on Health that named dementia the godfather of chronic diseases. So it is enshrined in their document in chronic diseases, and it's the first time the House of Commons Standing Committee on Health actually named dementia a chronic disease. So that was a huge step forward. Despite that fact, as you heard, Canada is the only G8 country that does not have a national dementia care plan. So that as a country, we are real laggards in this area. So what does that mean? Is that, is a dementia care plan regionally, provincially, and nationally nice to have, or is it need to have? And it's really become a need to have investment at this time. So these were fantastic presentations explaining how you would develop such a plan and why we have to do this. I'd like to create a bit of a burning platform. This is really a need to have thing at this point. ISIS, so the main institute for health services in the province of Ontario, and CIHI, the main institute for Canada, have both clearly demonstrated dementia is the #1 diagnosis driving up alternate level of care rates. Those are ALC rates. Those are the rates of people who are in hospital who no longer need to be here, who are preventing patient flow, which is resulting in other patients coming in the hospital being left in the hallway. So it's very clear that dementia is it's becoming a very primary diagnosis for the healthcare system to deal with. The problem doesn't so much lie within the acute care hospitals. There's a lot of work that needs to be done in terms of dementia care in acute care, but the problem lies in the fact that we do not have an organized community-based healthcare system. We have elements of a community-based healthcare system, but we do not have it fully organized in terms of having CCAC primary care and all the specialists sort of within one governance system. And because of that, people who could have been kept at home and cared for at home and in the community end up in hospital, and once they're in hospital, there's nowhere for them to go. So the hospitals are really the default setting. As a society, we're paying for care in the most inappropriate and most expensive setting possible because we do not have a community healthcare system. So as I said, CIHI and ISIS have clearly demonstrated that dementia is now central, and if we don't deal with this, if we don't develop a better system, this will crush the healthcare system as a whole. We will not be able to function within 10 years, it would be my estimate. Our Champlain LHIN has been really visionary. They've looked at all of this data and they have invested in this initiative. This is the start of an investment, the start of a rollout of a regional plan that the rest of the province is looking at. So our Champlain LHIN are really provincial and probably national leaders here. That being said, we still have setbacks. When we have people look at the data that ISIS and CIHI looked at was very, very high level. They looked at multiple databases and they were able to pull out that signal that dementia is a hidden diagnosis, the hidden driver that others couldn't find. We see other evaluations coming along that don't have dementia in it as a main driver. And why does that happen? It happens because they're flawed analyses. What they do is they look at the reason why people are admitted to hospital and they assume that's the reason they're not able to discharge the person. So the reason you get admitted to hospital is because you have pneumonia and heart failure. That's not why you can't be discharged. You can't be discharged because you have dementia. The dementia signal does not come out. So we still run into situations where healthcare decision makers are using flawed, inaccurate data, and those setbacks are going to continue. So how do we move to a really robust community healthcare system that includes caregivers directing us, That includes primary care, CCC, and specialists. I think the best way to do it, in my mind, is to have two groups involved. One is the healthcare providers developing systems that Cal talked about. But number two, the initiatives will never move forward unless caregivers are involved, as they are with the Mind the Gap group. If caregivers, seniors, and seniors groups do not get involved, these things will not move forward. Healthcare decision makers really take the word of caregivers, of persons suffering from different diseases, and seniors very seriously, because they're not special interest groups fighting for their specialty. They speak for the public. So until we really integrate our efforts between specialists, primary care, CCAC, and seniors and caregivers, I don't think we're going to move forward. So I'm seeing the beginnings of a great movement here. So this is no longer nice to have, this is need to have. We have a burning platform. We have to make sure that our healthcare decision makers all remain aware of this, and this remains on the top burner. So I've taken the privilege of being one of the MCs to pass on that perspective. So now I'm going to open the discussion up to the group to ask questions. We're going to start with the OTN sites first, because the civic site, people can always come down and trap the speakers and ask them questions afterwards. So any questions from the OTN sites?
Hello.
Yes?
Oh, hi. It's Jody Lusk from the General Campus. I wanted to just say that was an excellent presentation, and Dr. Ribeiro, the geriatric psychiatrist, was here as well, but he had to attend the meeting. But we just had a question about implementing dementia care into acute care, and if you foresee any strategies coming up in the near future to address dementia care.
I think step one is, first we have to, I think we have the attention of senior administration in the different hospitals, and that's a great first step. We're making our case, and we're making it very coherently. Step two, they're really asking the question you're asking, so what? So what do we do? And people have different ideas. In my mind, good dementia care in acute care means, number one, being able to identify the problem early on. There are so many people you see who do have dementia. It's not listed anywhere in the chart, even when it's diagnosed. And as you heard, 2/3 of people with dementia don't have the diagnosis. So number one, identification front end. Number two, get people who know about dementia care, such as geriatric medicine and geriatric psychiatry, involved in their care early on in the course of the illness. I'm going to lose count. Number three, if I lose count, just put up with me. Number three, good delirium care, delirium prevention care, doing everything you can to prevent the delirium. When people with dementia develop delirium, it takes a long time. It can take weeks or months to come out of that acute confusional state. Number four, get them up and moving very quickly. So that's the Move On project. It's been very clearly established when people stay in bed and they're not eating well and not exercising, they become delirious. Number five, link them up very early with post-discharge services. Let them know that the person's in, that they're going to need services, and start setting things up early. That's why you need to have the early identification. So I think there are a number of early steps that we can envision. It's a great question. It's something we need to sort of work on. It's part of the plan to work on that. So it's not necessarily starting medications for dementia in hospital. That it's the wrong time to start those medications. That's when people are most prone to having side effects. It's really making sure people remain as stable, avoiding delirium as much as possible, making sure they're eating, drinking, getting off drugs that cause delirium, making sure they're mobilizing, getting up on their feet quickly, and linking them up to the community very quickly. So those would be the sort of at least the first tier steps.
Hi, I'm Miss from the Royal. We have a question here too, or a statement.
A statement sounds more ominous than a question. Go ahead.
Well, I was just in response to that, because I work over at the Montfort Hospital part-time as well. It's Andrea Stewart. I'm a geriatric psychiatrist at the Royal and at the Montfort sites. And I love the GEM nurses that are in the emergency rooms now. I think they do a really good job, and it's a great model, the fact that it's not dependent. The triage nurse or the emergency room nurse can sort of trigger a referral to a GEM nurse who can do a more in-depth geriatric specific assessment and help send that person in different directions based on their outcome. The other thing they have started there now is a model where it's a hospitalist hospital. The hospitalists can admit people with dementia as a chronic condition to the inpatient psychiatry unit for their acute medical issue, such as a urinary tract infection or a pneumonia, because knowing that that person may have behavioral problems or other reasons where they could benefit from a higher ratio nursing in a private room. So they go into a different environment than our typical sort of 4-bed medical unit and get the follow-up care. So there are some initiatives in acute care hospitals, but kind of like what you were saying, it is still piecemeal and not an overall part of the system necessarily. So it'd be great to hear more stuff working through the acute care system and long-term care homes as well as within the community.
So thank you for those comments. They bring up two very important points. Number one is hospitals really can learn from each other. You see this all over healthcare where good things are done in one hospital, one region, the other hospital, the other region don't know about it. There's very little sharing of positive experiences between different areas in healthcare across the province and country. And number two, there is a much bigger role for geriatric psychiatry and geriatric medicine in acute care hospitals around the region. We really haven't gotten enough geriatric psychiatrists and enough geriatric medicine specialists in the different acute care hospitals. It's a missed opportunity. The hospitals are paying the price because people are deteriorating unnecessarily. We really need to look at that early screening, early pickup, early involvement of these specialists. And I would throw care of the elderly physicians into that specialist mix. These care of the elderly, geriatric psychiatry, geriatric medicine are the three specialists. Did I miss something? Yeah. They were cheering. That's good. That's better than the opposite. Are the three specialists that are trained to care for people with dementia. I think internists do a fantastic job, but their job is to keep people alive when they have pneumonia, sepsis, etc. It's not their job or their specialty to care for people who also have dementia. They need help, and we need to get that link in there. We'll jump to the Civic. Any questions from the Civic? There's a microphone that Marion will run around and hand to you if you have a question.
It's a statement, maybe with a quick question. First of all,
I'll get you to wait for the mic so the OTN sites can hear you.
Marcella, I wanted to thank you for just being so brave and so strong and so amazing. You're a role model for us. So thank you for sharing. The type of raw emotion that was conveyed, I think, really does have an impact, and I hope you have lots of opportunities to speak publicly, to share what the realness is of the experience of caregivers. I wonder if you could just talk a little bit about the stigma. You mentioned that there's still a stigma, and I think that's something that we have to get past in terms of physicians even accepting our seniors as patients. I hear a lot from my clients. I went to try to have a new doctor, and I was told it's too much for the new doctor. That's part of the stigma. Do you have any comments on that?
Yes, I do. I believe that people are a little bit afraid, and they don't really know how to deal with it, and they want to be away from it. They have this notion that the people with dementia are not people. They cannot function, and you feel very lonely, and you have this separation from what you do. And I think that they have to learn that there's nothing, they can be normal, they can talk to them. And even if they don't, it is too bad that they really feel that there is this thing, and you do feel that people will not come, will not invite you, will not be there for you because they feel that they don't know how to cope with it. So that's it's something that has to be worked on. Thank you. You're welcome.
So I'm going to close down. I can't think of a better place to end, but if I could ask people to bear with me for just 2 minutes for announcements. Before we forget, I think we should thank Marcella and Cal for coming here and being courageous and telling us what they're doing. So if you could bear with me for 90 seconds, our next regional rounds are on Valentine's Day. That's February the 14th for the males out there who forget until February the 13th. It'll be Dr. Joyce Dion discussing the art of caring for others, taking self-care to heart. So I'd ask people to hand in your evaluations. We use your feedback to plan these presentations and to plan the topics. If you can't read the handouts, go to our website at www.rgpeo.com. Everything will be uploaded. If you need credits for gerontological nursing certification, pick up their certificate when you leave. And I'd like to thank everyone for attending and thank the OTN sites for joining us.